So PACER actually started back with my thesis and gray matters. But the focus on PACER really became I don't know, it was one of those things that was almost meant to happen. I was presenting the gray matters research to our faculty at one of our usual faculty symposium. And Deb Marshall and Tom Noseworthy, both from Community Health Sciences, came up afterwards and said, "Do you think you could use the same methods to teach patients to do research?" Serendipitously, the Canadian Institutes of Health Innovation, which that's what it's now called, had a call for papers or research projects in the area of patient engagement. But it had to be located within the health system. You know, they weren't going to give the money to the university. It had to go through the health system. And that's when we connected with Tracy Wasiluk, who was one of the directors of the Strategic Clinical Networks. So she became the lead person in the grant. And we ended up setting up a very innovative partnership that has been published and it was quite remarkable, that had the Strategic Clinical Networks, the University of Calgary research teams, and what that was becoming known as PACER, Patient and Community Engagement Research. And that was quite a step forward, you know. I mean, I brought the academic, the research material and the teaching processes, but it really became a unit willing to take risks. And without those risks and a champion to really support that, innovation doesn't happen. And so to me, that was the magic spice for how PACER actually got started, was that a link to the past, to research processes, and then moving forward into this. So the grant itself, again, was extended. We managed to extend it from 1 year to 3 years. But at the end of that time, when the money ran out, nobody was funding radical new programs like this. So we had to find a way to fund ourselves. So we came up with a contract base. Nowadays it would be called a social enterprise. And so what we did is, for research teams who wanted to have patients trained, we set up a contract that allowed them to sponsor a certain number of patients to do research in their research area. And we also then developed research service contracts for teams that wanted to do patient-engaged research. Being able to do research with teams really enhanced what we had originally thought. We had thought that if we trained people about research, that they'd be able to inform the strategic clinical networks, and they did. They became leaders in patient engagement, not just in the strategic clinical networks, but in national health teams and government bodies with physicians, so that whole notion of being able to conduct research really legitimized the leadership capacity of the graduates from the program. And that was really an exciting thing to see. I mean, those early graduates, in effect, took over in terms of finding ways to work with research teams, and it was a real collaborative venture between the graduates and the people from the university who were working with them to oversee the ethics and the quality of the research. Then we came to a point where the university was asked to look at a special grant that was coming from the Indigenous sector within the SCNs, and it was a cancer prevention grant. And it required us to teach Indigenous students throughout the province. And that was out of our pay grade. You know, we'd gotten by with basically me and a part-time administrator running the program, but that grant was way too big to be able to do that. And at that point, we came to continuing education. You know, this was a course that I ran in my basement, or I ran in different places. At that point, I had just met Sheila. She'd just come to continuing education. And I said, I've got a proposition for you. Would you like to take over delivering this program that had a curriculum, had a methodology, etc.? And bless her soul, she jumped without really realizing what I think, what all of us had no idea where it was going to end up. So miraculously, it took almost no time at all for us to work together to put together a certificate in patient and community engagement research. We took it through all the levels of the university, so it became a university-approved certificate. And that's basically the beginning of PACER as it now stands. The whole notion of the ability to train patients to conduct rigorous and engaging research really was based on the contributions of many different people in many different programs. And it is unique. You know, I have not yet found a program internationally that has a recognized educational background or a program to train patients to do authentic research that gets published and implemented. Up to the point of my thesis, I'd spent a lot of time developing and evaluating programs that were positive and helped people with disabilities, mental health, seniors, Indigenous people, to create programs that were what they wanted. But because of that experience with CALE and the research I had done, I really moved into two more major research projects. The first one was called Gray Matters Now, and it was happened just because of the Kirby Center, just down the street here. And the seniors contacted a couple of us from the university because they were tired of being the burden on society as the focus for research that was being done in gerontology and geriatrics. And they really wanted to know enough about research and to be able to do research to challenge that impression that they felt they were burdened with. So luckily, the Canadian Institutes for Health Research had a Catalyst program for innovation. And I talked to them, and they were quite delighted with my thesis. So they sponsored a Catalyst grant to turn my thesis method into a curriculum to teach seniors to how to do research. And that was supposed to take 2 years, and it kept adding more and more things to it, and ended up with a book written with seniors. I come from a history of disabling conditions myself, and I've been so motivated by people with really complex conditions who've learned to manage and control their own destiny in terms of their healthcare. And to me, that's really what's been missing in the way we deliver health. And with the difference, the transformation of health right now, we've got an aging healthcare system. And it's cranky. You know, it's hard to innovate within the system. And we've also got these massive influences pushing the healthcare system to change. And I won't go into all the details of that, but for me, the most important thing is the dramatic changes with digital health. It's making a major push to reinvent healthcare. And if we don't involve patients in that, it's going to be a nightmare. So my motivation, especially in the last 3-4 years, as I've been really working on a new book called The Science of Engagement in Health Research and Innovation. If we don't learn quickly how to do this, how to have a patient perspective of the opportunities that are coming up, they're going to end up as threats. It's going to dig deeper into the systemic discrimination that we have right now. So for me personally, this is what's driven my entire career, is to use research and innovation to establish people's right to manage their own health care. I was the director of the Disability Studies program, and we were always fighting health. But I knew that health care really needed to learn from people like seniors and disabled people and people with mental health concerns, that they can manage their own care and live their own lives. And that had to happen. And so I really felt that PACER was the way to help the healthcare professionals, starting with researchers, to understand the capacity of patients to do that. Because unlike any other civil rights movement or any other emancipatory movement, patients are stuck. They really are. They're in a system that literally controls their life. They don't want to take any risks to alienate that system. So they're very cautious, and it's hard for them to take control. And those who do tend to be people who have a lot at risk, who have chronic conditions, who really need to take their own control, or else they're going to be defined by their disability or their healthcare condition. So that was my goal, initially was to help professionals and researchers understand that patients are important. And that's shifted dramatically. It's no longer just something that's good for patients. I think it's essential for healthcare. To me, that's why this is so important, that it comes from what patients have said as they become PACERs. And I guess from their perspective, up to the point where they had been trained, they were seen as an advisor, and they told their story. They didn't have the skills or the training to be able to say, hold on, have you ever thought of? So that was the major impact. These people gained confidence in the knowledge that patients had, and they had the ability to speak up for that. And so that was the major impact. They were able to define their role in those relationships as equals, and to say, yeah, no, it's important for nurses to do research on patient experience, because they need to improve the care that nurses provide. But if you want to know the impressions of patients in terms of what they need to flourish, it needs to come from patients. And that only comes from patients when they feel safe enough with the people who are doing the research. One of my first colleagues in the new social movements said he called research the bedpan. He said they were always trying to produce things to make sure they gave the researcher what the researcher wanted to see. And I know that's a little bit controversial, but I think that patient culture is there. It just needs to be cultivated. So I think that is the major impact of something like PACER. It's not the cost. It's not the improved service, which happens. It really is that ability to change the relationships in research, and those relationships then produce research that influence the conduct within the healthcare system. When PACER started, I'm convinced that PACER only took off because it was in what was called the third industrial revolution of communications and computing. And that was that was a breakthrough. Patients had access to information. They started collecting their own data. They had their binders with all of their reports. They were taking questions from the internet to the doctor, much to the doctor's chagrin. But I mean, that opened up the ability of patients in healthcare to feel confident enough to actually say something. Our healthcare systems globally are really struggling under systemic discrimination. Access to healthcare is marginalized. The availability of treatment is marginalized. The ability to have options is marginalized. And we just can't continue with that any longer. I mean, it's no longer viable. University community in Canada has adopted what some people call the JEDI. It's justice through equity, inclusion, and diversity. And that's what PACER is needed for. It's to be able to work with those communities that have been excluded and create a bridge between those communities and healthcare research. Those students who come to PACER have career goals. While they'd like to be able to do research, they get wrapped up in where their career takes them. And so it's my belief, and it's from talking to graduates who are working in such a wide range of occupations now, that what they take away is that emancipatory fervor, that the work they do needs to include who they're working with. Wherever they are, they're not just taking the research component, they're taking that emancipatory understanding that healthcare doesn't need to only be compliance. There is that element and that responsibility to change the current healthcare system to make sure that people are seen as capable and given opportunities to take charge of the decisions that impact their lives. First one is come prepared to work. It's not something you can do off the side of your desk. It's not just about learning new skills. It's about figuring out who the heck you are as a patient and how to use that. And that can be hard. And we provide lots of support in that, but it really is a tough go. The second thing would be, it's not about you. PACER research is not about being a super researcher. It's about working as a team. And we teach that by doing research as a team. And that's hard work. It's moving from me to we, and that is never easy, especially when each of your identities is on the line. Like each of you are bringing who you are as a patient to the research team that's learning to do research. So it's really conflicted, and it can be hard. I guess the last thing is be prepared. I mean, most people who come think of health research as being clinical research, which is objective and it's standardized and it's very formal and you're the boss. But peer research in its essence is emancipatory. It's there to help people dig deep and share their expertise and to create solutions to problems that can be acted on. It's about exploring this emancipatory foundation of peer research that is going to change and is changing the face of healthcare in Canada. It's the beginning of a new paradigm shift. It's the beginning of a way of working to the future, towards a future that none of us really know what it's going to be like, because the potential is there. We just have to make sure we can have the capacity to respond to that potential.